Or people are on holiday, ma'am?
Parul's back, I think. She's back today morning. She was flying back.
Okay.
So I think she was
Okay.
quite happy that we got it today. And
Uh-huh.
Shubha has said yes. I
Uh-huh.
don't know about Rohaina. She has said yes. I don't know about what's her name? Nazneen.
Nice.
Evidently, Ishili doesn't come in. I'm keeping my fingers crossed. I don't know about Shanti.
Mm-hmm.
What is it? Zaldeep का कभी lectures, 2 lectures, which Thursday should we catch? Because Jaldeep's lectures, he's going to take 2, na, on effective communication and skills.
Right. Ma'am, but this is very good. This
Huh?
information, electrophoresis and this.
Yeah, it's a good presentation. Well,
It's a very
Bonita and
good
I
one.
thought we might as well put it on because in the West it's quite common. यहाँ इतना नहीं कराते हैं, except you have cases of multiple myeloma or protein का कुछ deficiency है.
Very nice, ma'am. Lots to learn. I went through it. It's very good.
Then I think you wanted to take a round of the lab, no?
11 and 18
Parul
June.
also wants to come, huh?
I know, ma'am,
11
but
and 18 June.
11 and 18 June, Jaldeep will be on. So I also better warn him to get he's got things ready. So 11 and 18 June. Okay.
11th and 18th.
Remember, huh? I'll talk to him this coming week. Monday I'll talk to him. What's the next one?
Urine analysis.
Yeah, we're going to do a very quick scan of urine analysis. Then I'm hoping that Shanti, towards end of, I've given her that much time, end of June, she comes in with, I don't know what she wants to present something on the kidneys, the renal function.
Right.
What's the time? Time is coming up?
4 o'clock.
Rohaina.
Yes, hi.
Nice to see you, ma'am.
How are you, ma'am?
I'm okay.
How are you? How's your health?
Okay. What God gives, we take. Haji. Only thing I'm a little deaf with the right ear. Huh? I still can't hear 100%, but at least the pain has gone. The terrible, terrible pain has gone. But there is a little echo.
Okay. Yeah.
So that's
Take
it.
care. Yeah. Take care. Take care.
How's it going over there?
Oh,
Mr.
well,
Trump
everything is fine.
and Mr.
Coming back.
Netanyahu?
No idea. I'm not really looking at the political side. I just want to
No,
know things to open.
because I have CNN all the time, so I take a look at it.
Yeah. Yeah. No, they have only there's 2 flights still operating.
Ah.
There are so many other flights not operating.
Okay.
So still there's a little bit of,
All right, Parizad, you made it.
expensive.
Parizad, unmute Parizad. Parizad is in Lonavala, so she wasn't very sure whether she would make it. She's made it.
Good afternoon, ma'am.
Good afternoon. Good afternoon. You're reporting from Lonavala, is it?
Yes, ma'am.
Good. We'll wait for 1 or 2 minutes more. Is Lonavala cool? Because Bombay, as you know, is terrible. It's really terrible. We'll wait for 2 more minutes. Is that? Hold on. Presentation hold on. इसको load कर दो ना. It keeps coming in the way. Right. We'll start it in about 2 minutes time. Okay. Let's see who comes in. I'm sure Dr. Shubha will. So she'll solve the problem for her.
Yes.
यहाँ कोर्ट में बेटा टैक्सी को है
This one.
बहुत यस मैम
I'll see. Usually I get, but on that day only was
फिर था क्या वो दिन पे टुडे इज फ्राइडे अगेन नो थ्री पास को
4-3.
हाँ
4-3.
Okay, let's start. Okay, guys, we are starting. All right. All right. So, in this presentation, we are going to take a look at protein electrophoresis and hemoglobin electrophoresis, the patterns. And like I think I was just telling Meena that it is so common in the West because it helps you identify so many problems. Over here we are getting to it. So in the second point I have said significance of different bands in protein electrophoresis is related to various diseases like multiple myeloma, M protein, monoclonal gammopathy, cirrhosis and so on. In hemoglobin electrophoresis, you will be able to take a look at the various types of hemoglobins. The normal HbA and the other variants like HbF, HbA2, HbD and so many others. This will give you a better insight into various inherited anemias like sickle cell and thalassemia. Hemoglobin electrophoresis as well as protein electrophoresis can be done on various support medias like agarose gel, which is very common, polyacrylamide gel, and high performance liquid chromatography, which is the gold standard, I should say, which is the gold standard. All right, let's go on to the other slide. Difference between chromatography and electrophoresis. Chromatography is a technique, I'm sure you all know, in which a sample components are separated based on how they distribute between a stationary phase and a mobile phase. Electrophoresis is a method in which sample components are separated by their different rates of migration in an electrical field. Keep that in mind. Now this is a very, very common electrophoretic pattern for the proteins. So serum proteins can be grouped into 5 fractions by protein electrophoresis. Albumin, which represents almost 2/3 of the total serum proteins, and you can see it here, followed by alpha-1, alpha-2, beta and gamma. So albumin will represent almost 2/3 of the total serum protein. Alpha-1 composed primarily of alpha-1 antitrypsin and alpha-1 acid glycoprotein. Alpha-2 composed primarily of alpha-2 macroglobin and haptoglobin. Beta composed mainly of transferrin and C3. Gamma composed primarily of the immunoglobulins and antibodies. So keep this in mind, this is the basic structure of protein electrophoresis. So here we go, we've got protein electrophoresis, you've got albumin, largest fraction, alpha-1 antitrypsin present there. In alpha-1 you've got haptoglobin, ceruloplasmin, alpha-2 macroglobulin in the alpha-2. In the beta you've got transferrin and beta lipoproteins, and then you've got the immunoglobulins in the gamma. And you can see the fractions below. So usually this strip is put into a reader and you will get the quantitative estimations. Alright. So we come to monoclonal gammopathy. You'll hear this very often, paraprotein. So monoclonal gammopathies are conditions in which abnormal proteins are found in the blood. These proteins are produced from a small number of plasma cells in the bone marrow. The most common condition linked to these abnormal proteins is monoclonal gammopathy of undetermined significance. And take a look at the picture. So you've got the albumin, you've got alpha 1, alpha 2, beta, and you can see the beta is dipped, and you've got the gamma. Huh?
Someone was joining.
Somebody's coming in, we'll wait, okay? You continue. Alright. Alright, so this is the pattern, something going. You can see it's not a very normal pattern, isn't it? Alright, let's go to the next slide. You've got MGUS causes symptoms. Diagnosis is often done. Dr. Chogle wants to join in. Just a moment, guys. I think she's not able to join in. How's that? Can you contact her and ask her why? What's happening? Hello?
Yes, ma'am.
Guys, we just wait because Dr. Chogle wants to come in and I think she's not able to join. There's a message on my mobile here where she's trying to.
Ma'am, no. Video will get cut.
Guys, just hold on. चलना क्या हुआ? What happened?
She's not picking up.
Uh,
Hello? हाँ ma'am, you are not here. Try to join again. हाँ.
shall we continue?
She is coming.
Huh?
She is coming. Let me.
Guys, it would be a very good idea that when the lecture has started, don't try to call me on my mobile. Yeah, she's on now. Please try to get and talk to Nikat. All right, Dr. Shubha's on. All right.
Thank you. I'm in.
All right. So let's continue.
Ma'am, go ahead.
All right. So we're talking in terms of multiple myeloma. So diagnosis is often done with lab tests called electrophoresis. Because MGUS is not harmful, it doesn't need to be treated. Just go back to the other slide. So we come back to. Yeah. So we've got MGUS is what the most common condition linked with these abnormal proteins is monoclonal gammopathy of undetermined significance, which we call MGUS. All right, let's go on to the other one. So MGUS causes no symptoms. Diagnosis is often done with the lab test called electrophoresis. Because MGUS is not harmful, it does not need to be treated. MGUS may lead to more serious conditions like multiple myeloma. That's why we have to be careful. Non-Hodgkin's lymphoma, which is very, very sad, I would say. Plasma cell leukemia and primary amyloidosis. So we come to multiple myeloma, as the name tells you, multiple. The protein electrophoresis test is often used to find abnormal substances called M proteins. The presence of M proteins can be a sign of a type of cancer called myeloma or multiple myeloma. Myeloma affects white blood cells called plasma cells in the bone marrow. All right, and this is not a very, very healthy sign in a patient. So we come to M protein. The M protein is characterized by the presence of a sharp, well-defined band or peak on the electrophoresis pattern. Once the M protein is identified or suspected, electrophoresis is followed by immunological characterization of M protein in both serum and urine by immunofixation or immunotyping using serum or protein immunoreactions with appropriate antiserum. The second level testing enables the determination of heavy chain IgG, IgA, IgM, IgD or IgE and or light chain kappa or lambda, which is maybe involved. So now we come to polyclonal gammopathy. Infectious, inflammatory or various reactive processes may be associated with broad-based peak or band in the gamma region, and you can see it over here, put an asterisk there. This pattern suggests a polyclonal increase in the immunoglobulins. Liver diseases, autoimmune diseases, chronic viral and bacterial infections, and various malignancies may cause a polyclonal rise in the gamma fraction. And you can see the band, how abnormal it is in the gamma region. You can see the double bands, right? Let's go further. So you come to hepatic cirrhosis. Again, very, very sad. I'm using the word sad. The serum protein changes occurring in liver diseases associated with parenchymal damage are characteristically decreased in serum albumin and increased in the gamma globulin fractions. You can see the albumin is down and there is an increase, there's a bridging between beta and gamma, and that's quite characteristic in the liver conditions. So beta gamma bridging in the electrophoretic is highly characteristic of hepatic cirrhosis. So keep this in mind, the beta gamma bridging. So we're coming back to hepatic cirrhosis. So the variation of alpha 1 and alpha 2 and beta fractions is inconstant, and is not of great diagnostic or prognostic importance. So alpha 1, alpha 2, beta is fine. The increase in gamma fraction is polyclonal in nature and is due first to increase in IgM fraction followed by an increase in the IgG fraction. Elevated IgA fraction is not as constant or prominent. So you know you have your 5 antibodies and these are among the 5 antibodies. Right. Then you got nephrotic syndrome, problems with the kidney. Patients with nephrotic syndrome usually show low albumin, here we go, and total proteins, but this condition can also be produced by increased alpha 2 and beta fractions, and you can see it happening over here, gamma being down. Bands in either of these regions may mimic a monoclonal band. When performing gel electrophoresis, a band may be visible at the point of application, at the POA. Alright? Protein losing enteropathy. Here you're losing your proteins. Protein losing enteropathy is characterized by the severe loss of serum proteins into the intestine. So you can see it, a decreased albumin, decreased gamma, increased alpha 2 macroglobulin. Albumin loss through the gastrointestinal tract normally accounts for 2 to 15% of the total body degradation of albumin. But in patients with severe protein losing gastrointestinal disorders, the enteric protein loss may reach up to 60% of the total albumin pool. Shubha, just would you mute your machine, please?
Oh, yes. Sorry.
The serum protein level reflects the balance between protein synthesis, metabolism, and protein loss. Protein losing enteropathy is characterized by more loss of proteins via the gastrointestinal tract than synthesis, leading to hypoalbuminemia. It is not a single disease, but an atypical manifestation of other disease where you lose proteins. Maybe a combination of other things. Then we come to hypogammaglobulinemia. You can see the gamma globulin is down. A depressed gamma fraction, hypogammaglobulinemia, is consistent with immune deficiency and can be associated with primary amyloidosis or nephrotic syndrome. Primary amyloidosis is a rare disorder in which abnormal proteins build up in tissues and organs. Clumps of the abnormal proteins are called amyloid deposits. Then you have the immediate and delayed response pattern. Immediate response occurs with stress or inflammation caused by infection, injury, or surgical trauma. Normal or decreased albumin and increased alpha 1 and alpha 2. Delayed response occurs with chronic infection. Example, chronic liver disease, cancers, autoimmune diseases. Normal or decreased albumin, increased alpha 1 or alpha 2 globulins, and increased gamma globulin. So these patterns you may remember or you may not remember. The one who does electrophoresis every day, it becomes very easy for them to see the pattern and remember the pattern. So here you have the normal pattern. You've got albumin, alpha 1, alpha 2, beta, and gamma. Then in B, you've got the immediate response pattern. And in C, you've got the delayed response pattern. And you can see how the patterns change. A, B, C. Then you've got the others. You can see the albumin is down. Alpha 2 is up. Gamma bridging is there. Then in E, you also got albumin down. Alpha 2 up. Gamma down. And then you've got albumin down, and then you've got a spike on the gamma globulin. You can see the 6 different patterns in front of you. And then we come to hemoglobin electrophoresis, equally interesting, especially in cases of anemias and inherited anemias. A hemoglobin electrophoresis test is a blood test used to measure and identify different types of hemoglobin in your bloodstream. Hemoglobin is the protein inside red blood cells responsible for the transport of oxygen to tissues and organs. Genetic mutations can cause your body to produce hemoglobin that is formed incorrectly. This abnormal hemoglobin can cause too little oxygen to reach your tissues and organs. And you know that if the oxygen is depleted, problems will happen. So what are different types of hemoglobins? So there are hundreds of different types of hemoglobins, that's true, and they may include hemoglobin F. This is also known as fetal hemoglobin. It is the type found in growing fetuses and newborns. It is replaced with hemoglobin A soon after birth. Hemoglobin A, that's what you and I have, is also known as the adult hemoglobin. It is the most common type of hemoglobin. It is found in healthy children and adults. Then you've got the C, D, E, M, S, and like there are quite a few many. These are rare types of abnormal hemoglobins caused by genetic mutations. So there are different types. In infants, hemoglobin is mostly made up of hemoglobin F. That's F is fetuses. Hemoglobin F still makes up the majority hemoglobin in newborns. It is quickly declined, it declines by the time your baby is 1 year old. So here are the age groups. Hemoglobin F percentage, newborn 60 to 80%. By the time the child is 1 year, it's about 1 to 2%. So in adults, the normal levels of types of hemoglobin in adults are, here we go, percentage, hemoglobin A 95 to 98%. Hemoglobin A2 2 to 3%. F is 1 to 2%. S is 0, that's your sickle, and C is 0. Why a hemoglobin electrophoresis? Why is it done? You acquire different abnormal types of hemoglobin by inheriting gene mutations on the genes that are responsible for producing hemoglobin. Your doctor may recommend a hemoglobin electrophoresis test to determine if you have a disorder that causes the production of abnormal hemoglobin. Reasons your doctor may want you to do a hemoglobin electrophoresis test include, as a part of routine checkup, your doctor may have your hemoglobin tested to follow up on a complete blood test during a routine physical. Then depends on the patient's signs and symptoms and the CBC report, especially when you start tracking the hemoglobins. To diagnose blood disorders, your doctor may have you to do a hemoglobin electrophoresis test if you're showing symptoms of anemia. The test will help them to find any abnormal types of hemoglobin in your blood. These could be a sign of disorders including sickle cell anemia, thalassemia, polycythemia vera. If your results show abnormal hemoglobin levels, they may be caused by, let's see, hemoglobin C disease, a genetic disorder that may lead to severe anemia, rare hemoglobinopathy, a group of genetic disorders causing the abnormal production of structure of the red cell, it upsets that. Then you've got sickle cell anemia, you've got thalassemia. Your doctor will do follow-up tests if the hemoglobin electrophoresis test shows you have abnormal types of hemoglobin. So the signs, symptoms, and the repeated CBCs will let your doctor go for these different tests. How is hemoglobin electrophoresis performed? In the laboratory, a process called electrophoresis passes where you passes an electric current to the hemoglobin in your blood sample. It's not that easy, it has to be loaded on to a support medium. This causes the different types of hemoglobin to separate in different bands. Your blood sample is then compared to a healthy sample to determine the type of hemoglobin present. So you usually collect 6 ml into your EDTA tube. You require about 5 ml whole blood. Minimum 1 ml is needed. Alright? So this is how the hemoglobin electrophoresis is performed. You can see it's loaded on to the gel. A current is passed, and after some time the bands separate and the bands are quantified. Alright? So here we go. You've got the bands, and this is your citrate agar pH 6. This is your point of origin, POA, and you've got A2 quite close, right? You have to separate it, and you've got bars. Then that's your normal pattern. In the abnormal, you can see many things coming. You could see you've got point of origin, you've got H, then you've got S, you've got A2, and you've got F and R's. So it depends on the bands that come through. Separation of common hemoglobins and variants on alkaline gel electrophoresis is done. The anode, that's a positive, is on the left. In many common depictions of this process, the anode is on the right. Then the image is reversed. So you've got the alkaline electrophoresis. You can see that you've got A followed by F, S, D, G very close. You've got A2, C, E, and O, and you've got your point of origin. So that depends on where your point of origin is, on the anode or the cathode. Your migration patterns come through it. Sickle cell positions, normal, abnormal. So position along electrophoresis gel, the normal is this way. Then you've got the abnormal a little further up. It's not a very great side position. Position along electrophoretic gel, you've got sickle cell trait, and here you have a 50 mixture of A and B. Let's quickly get through something else. Alright. So beta thal, you've got major, minor, and normal. Who's coming in? Nazneen Sikna. Alright, Nazneen, you're in. We are at hemoglobin electrophoresis.
Yes.
Alright, so you've got somebody else. You've got your FA and A2. F major 10 to 98%, minor variable, normal less than 1%. Then you've got your beta thals, the pattern is beta thals. Hemoglobin A absent. In minor you got 80 to 90%, normal 97%. And your hemoglobin A2, which is your thal minor, you've got the major fraction is variable. In minor you got 5 to 10% increase, and in normal it should be about 1 to 3%. Okay. So laboratory methods to evaluate hemoglobin, and this is the gold standard: high performance liquid chromatography, weak cation exchange column. The ionic strength of the elutic solution is gradually increased and causes various hemoglobin molecules to have a particular retention time. Amino acid substitutions will alter the retention time relative to hemoglobin A. There is some analogy between retention time and patterns on alkaline electrophoresis. So here you've got hemoglobin electrophoresis, high performance, liquid chromatography, or capillary electrophoresis, the advantages. Hemoglobin electrophoresis provides qualitative analysis of hemoglobins, A, F, A2 and others, but high performance liquid chromatography, HPLC, or capillary electrophoresis, CE, allows quantification of hemoglobin fractions. If the aim is to detect beta thal alone, hemoglobin analysis by HPLC or CE can be selectively added when MCV and MCH is low. So you follow your CBC and your indices. Okay. Beta thal carriers are diagnosed by the presence of low MCV, keep that in mind, and raised HbA2. The latter is usually high, 3.5 to 7%, except in co-inheritance with delta thalassemia trait, or very rarely in carriers of silent beta thal or normal HbA2 beta thal. A very high level of HbA2, 7 to 9%, suggests the presence of a deletion mutation affecting the promoter regions of the beta glob gene. Some patterns of different hemoglobins are listed below. So if you are doing this every day, this becomes easy. And a quantification is also done. In areas where silent beta thals, normal A2 is found, beta glob genotyping can be performed. In a couple, if one partner is beta thal carrier, irrespective of MCB, MCH and HbA2 levels of the other partner. Rarely when elevated HbF is found, either delta beta thal or deletion types of hereditary persistence of fetal hemoglobin is suspected. So there are various combinations which can be present. So we come to polycythemia, in many cells. Polycythemia means increased red cell volume. Polycythemia is divided into two main categories, primary and secondary. Polycythemia can be linked to secondary causes such as chronic hypoxia or tumors releasing erythropoietin, abnormally increased red cells production in the bone marrow causes polycythemia vera. There are two main types. Primary polycythemia, there's a problem in the cells produced by the bone marrow that becomes red cells. The most common type is known as polycythemia vera, PV. Secondary polycythemia, too many red cells are produced and the results of an underlying condition. Why this happens? So we track the hemoglobin as well as the PCV in these patients. So you've got the relative and the absolute polycythemia. In relative polycythemia, the red blood count is not truly increased. But the PCV is elevated because there is less fluid in the blood, which makes the relative amount of RBCs appear to be high, related to be high. Absolute polycythemia occurs when more RBCs are produced than normal, and the count is truly elevated. And you can see the difference in the chart below, the relative and the absolute polycythemias. So we talk of terms of polycythemia vera. So the features are HbPCV and red cell mass increased neutrophils and platelets, normal NAP, plasma urate high, circulation erythroid precursors are there, hypercellular bone marrow, low serum erythropoiesis. That's the last part. So we thought we'd give you something on polycythemias. Nazreen, make it a point to attend the whole thing. You're coming in between. You've missed protein electrophoresis, absolutely.
Sorry, madam. Today we also had one internal
Haji?
for a machine instrument.
Okay.
So I had to go for examination.
Anything to ask for? Anything you haven't understood? Anything to comment? Shubha, anything that you would like to add?
Yes, should I talk?
Yes, please.
A very nice presentation indeed. I would like to say that this electrophoresis is one of the adjunct for diagnosis, but very much in cases like multiple myeloma. What happens is when the samples used to come to us, first was the patient's clinical examination by the oncohematologist at our place, Dr. Ruzbeh, and he used to immediately, once he used to examine the patient and he used to understand his clinical condition, he used to call me down or he used to speak to me on phone that please go ahead with the electrophoresis. He used to tell me that patient has subsequent results like that patient has a high ESR. But high ESR can always go in infections also. Then the second thing is raised creatinine. Creatinine used to be somewhere like 2.93. Third is the patient used to have proteinuria. The fourth thing is looking to the radiological findings or imaging. The patient used to have fitting pictures in the skeleton. So he used to call for electrophoresis. Then I used to get this kind of sharp band in the gamma region, which you have shown in the gamma region, the sharp steep band along with looking like the albumin fraction. I used to report that it is an M band. But during my failure, I also seen bands sometimes in beta 2 also, or somewhere in alpha 2, which I used to ask for immunofixation or immunotyping, because this band can also occur in nephrotic syndrome. And the patient used to have heavy proteinuria, low albumin. So I used to ask to go in for the immunofixation. At our place, we didn't have immunotyping. We used to do it on the capillary electrophoresis, and we had immunofixation. Then we used to also do kappa lambda light chains. He used to also tell me to do quantitative immunoglobulins, IgG, IgM, IgD, IgA, IgA. But mostly we used to do the quantitative, and also we had quantitative light chain studies where the ratio used to be inverse in multiple myeloma. either the kappa lambda ratio used to be low, because in that case when the lambda is high and kappa is low, so it used to give us a low ratio. But when the kappa used to be high and lambda low, then there used to be also in that case a high ratio. So I used to report to him that this is on immunofixation. We used to confirm the diagnosis that it can be IgA kappa, IgM lambda. So looking to the immunofixation, the picture, and also the kappa lambda quantitative light chain studies or immunoglobulin heavy chain studies, we used to finalize the reports, as well as it was also side by side accompanied by a bone marrow study, and that used to confirm the diagnosis, and we used to put the patient on chemotherapy and also steroids. So that is also very good. I've also seen you have mentioned about the bridging pattern in the cirrhotic patients. That is also a very good thing, that there is a bridging. I've seen this kind of pattern.
Beta gamma. Beta gamma.
Patient. Yeah, beta
It's
and
very
gamma.
interesting, yeah.
It is actually a bridging pattern. And there used to be a bridge, like climbing, as if we are climbing a bridge. So I have seen that also. I have also seen hypogammaglobulinemia, where there used to be deficiency, immunoglobulin deficiency. The patient was immunodeficient, and the patient used to get constant infections. So I've seen, in my tenure at British Candy, I've seen many pictures like this. Even we used to do the lipidogram electrophoresis, that is beta, pre-beta, alpha, where the first pattern used to be the precipitate, cryoprecipitate, then used to be the beta, which was correlating with cholesterol levels, pre-beta with triglycerides, and alpha used to quantitate the HDL cholesterol. So we used to do that pattern also. So I was fortunate enough that we used to do the electrophoresis pattern, and then when there used to be a raised creatinine, there used to be a raised ESR. Dr. Ubadia used to say, when I used to say that advice for immunofixation studies, advice for heavy and light chain studies, I used to write in the remark. So once when he came for the rounds, ICU rounds, he said, call that lady. Every time she is writing, every time, advice for immunofixation studies. But I used to tell him, I'm not writing for everybody. If the ESR is normal, if the creatinine is normal, then why do I write? I see that the raised creatinine is there, raised ESR is there, and fitting pictures are there, heavy proteinuria is there. Then only for confirmation, I used to advise for immunofixation, because immunofixation and immunotyping, they are, and the quantitative heavy and light chain studies, they are very expensive. But for confirming the diagnosis, I used to tell them, go in for immunofixation, immunotyping. So the pictures, the slides that you presented are excellent. Then in case of hemoglobin electrophoresis, I should say that people see horoscopes. I always tell, because there are many people who come to my place from Gaon during wedding and all. They say that we go through horoscopes. But I tell them that first do a hemoglobin electrophoresis, a hemoglobin pattern, because if two are traits, carriers, then it is a big pathetic scenario where out of the 4 children, one is a sickle cell thalassemia major. So instead of having a short life of the child, or thinking before getting conceived hemoglobin electrophoresis has to be done. Even I think before arranging for the marriage, it is very important. And another thing is that the alkaline electrophoresis that you said, excellent. I have seen sickle cell patterns also, and then it used to get matched with the sickling test positive, then HBS, because the HBS and HBB you said are on the same side. But if the sickling test is negative, then in that case, that fraction is HBD. So all these patterns are very helpful for diagnosis, since the clinician will always see that if the child is having jaundice, if the child is having joint pains, then we go in for electrophoresis, we also go in for a sickling test. So prevention is better than cure. So I think before going in for a marriage, to a marriage bureau, planning for a marriage, or even planning for a child conceiving, these electrophoretic patterns have to be done. They are very, very important in life, rather than tripping over our destiny. Then science has made so many things now available, because now precision medicine is there. So electrophoretic pattern is a very nice subject that you took in. Electrophoretic patterns are the need of the hour, and they have to be done. Excellent presentation. Thank you so much.
Any other questions? Anything you'd like to know? Nazdeen? So I no, unmute, unmute. I can't hear you.
Actually, I was not handling electrophoresis in my lab, so I could not comment on the what do you say, on the use of electrophoresis. Yes, of course, definitely it's a good method to distinguish between heavy molecules and their secretions and diagnosis. And what doctor said is correct. The sickling cell and the traits, knowing the traits. So this has been made compulsory by Dubai government in the premarital screening. Before the emerites they go for marriage, they have to compulsory do the screening so that these traits are known, because they saw an alarming increase in abnormal behaviors and structures in their populations. And over the last 10 years, this has been developed in the premarital screening. This is one of the premarital screening tests over here.
Needed.
Yes. Even for our small ethnic groups, our Parsi groups also, it is very helpful to know, since we are marrying internally. So it is very helpful to know if any traits come out before marriage. So we can also use it as a small community.
The hypergamma-globulinemia is also known as acute phase reaction. Acute phase reaction.
Parsis, of course, they need their G6PD, which now has become routine. The moment the child is born, with the blood group, the G6PD is done. And I'm glad that even the Bodhis, we have a very big Bodhi population where we work, and that is done in everybody, right? All the Muslim kids that come in, whether it's Bodhi or non-Bodhi, G6PD is done.
It's very important to do G6PD.
All right. Can we end in this place?
Yes, ma'am.
Okay. Thank you, doctor.
Thank you.
What is the next
Thank
one?
you, ma'am.
Yeah.
Thank you,
Urine
doctor.
analysis.
Okay, the next one is on urinalysis, okay? So we'll see you next Thursday. Hopefully, this Geo will not give me trouble.
When is the next one?
Next Thursday, it's on renal function.
Renal function.
Okay?
Okay, ma'am.
See you. Thank you very much.